Now we listen to Dr. Victor Fadlallah. He will give us a talk about corticosteroids and anticoagulation, when, how, and to whom. Dr. Victor, please.
Thank you, Mr. Chairman, dear colleagues. Sorry for the reading late. I have another lecture. First of all, I'd like to thank you all for sharing with us this marvelous scientific conference, and it's a pleasure for me to present this presentation about corticosteroid anticoagulation, when, how, and who. From the start, we have to say rapidly, we all know that COVID causes inflammation, and this inflammation through the monocyte cause cytokine storm, and also we have the most complicated scenario, ARDS, multi-organ hyperinflammatory syndrome, and even death. So what growth involves the heart disease? Rapidly, we can know that the macrovascular injury can be caused by COVID. So we can here use acute coronary syndrome, rupture plaque, or even it may lead to heart failure, myocarditis, and arrhythmia. Well, why corticosteroids? We all know that all the mechanisms that we've been taken here, myocarditis, it occurs with systemic inflammatory response. Myocardial infarction from increased demand supply mismatch and the cardiometabolic demand. Microangiopathy, cytokine induced activation, and arrhythmia even through inflammatory response. So all the inflammations lead to cardiac complication. So we have steroid to do it. But there is something I need to talk about. Steroids have two arms of action. Nuclear receptor action. This nuclear receptor action inhibit protein transcription, and this is a delayed effect of corticosteroid for the long run. But we need the non-genomic effect of corticosteroids, the rapid anti-inflammatory effect of it. Prednisolone is the list, followed by dexamethasone, and finally methylprednisolone. Methylprednisolone is the most potent non-genomic steroid. This is our point to say. So when to use the steroid? All of us, there is no steroid for the mild case, but why we start with the moderate cases? We can see here that the inflammatory process start from stage 2, shortness of breath and abnormal chest imaging, up to the cytokine storm. So starting the steroid early in the second stage is very, very beneficial. We have 3 studies which recommend dexamethasone 6 milligram daily. For the first recovery study, it was the first study to identify the steroid decrease in mortality. So it gets us, so you can use a steroid. Also in REMAP-CAP study used hydrocortisone 50 milligram. It was also said that steroid is very beneficial. Although the Cape COVID study said it was not significantly reduce the prevalence of treatment failure, but also we have ended this by the Codex study, which administered steroid increase in ventilator-free days for the particularly sick cohort. So, in the analysis of more than 7 studies, including Codex, Recovery, Cape COVID, say that use of corticosteroid in critically ill, again, in critically ill, including those with COVID-19, was associated with lower 28 all-cause mortality. This is the point. So once you decrease the mortality, it is very beneficial drug. How to administrate it? It is a second mission which looks to be very beneficial. Moderate cases, dexamethasone, we can give only 6 milligram. Never give a bucket and fill it with dexamethasone, give it the patient will die. Only 6 milligram or its oral equivalent. If the patient has severe dyspnea, respiratory rate over 20 or 4, CT showed rapid deterioration. In severe cases, we can use 6 milligram or methylprednisolone 1 milligram. We can see 1 milligram methylprednisolone can go with it. And in critically ill patient, we can use up to 2 milligram methylprednisolone. Again, no steroids in mild non-hospitalized patients. This is a rule. Our second topic, anticoagulation different. What is different and what's new? All of us, we know that anticoagulation we use it in COVID. What is different and what's new? According to the mechanism, there is something called neutrophil extracellular trapper. It traps the pathogen through fibrils, so it prevents it from getting to the circulation. These trappers cause thrombosis by fibrin. And also the ACE mechanism that we all know, it causes endothelial cell dysfunction and platelet complement activation, cause thrombosis. So we have thrombosis over the 2 arms. All of us also, we know that we can use anticoagulation if the D-dimer is more than 500 to 1,000 milligram per liter, okay, and also in severe critical patient. But my question here, who of the mild cases can use steroid? And this is very important for us as a cardiologist. Let us see the vena thromboembolism prophylaxis cohort specification good Padua in Italian hospital said that this for critical ill or a hospitalized patient score. If it is more than 4, so you have to do prophylaxis anticoagulant. So prophylaxis anticoagulant for our cardiac patient. If you have a patient with MI and also he is in a bed rest including going to the bus and getting back, you can see here we get bed rest more than 3 days, 3, and also acute myocardial infarction, 4. So your cardiac patient is high risk for prophylaxis. You have to give him prophylactic anticoagulants. Just noxaparin, we use it 40 milligram once daily for prophylaxis. For whom? For 50 to 100 kilograms. But if the patient is 101 kilogram, you have to shift to 40 milligram twice. It's important for prophylaxis. But if your patient is more than 150, you can use only 60 milligrams twice daily. For heparin use, don't use please three times every 8 hours doses because it increases bleeding risk. COVID or bleeding risk, yes. So you can use only twice 5,000 international rate heparin for bleeding or thrombosis. This is something that I show you. Bleeding can be exceeded in COVID and also thrombosis. How can we judge? As a cardiologist, we all know the Chas-Pascal score, and also we know the Hasbred score for bleeding and hemorrhage score for bleeding. But what are the score for hospitalized patient? It's called improved score for bleeding. We can, for sake of time, appreciate here that there is 3 points taking the highest grade, 4, 4.5, who can have active GIT bleeding, platelet less than 50, and the bleeding is past 3 months. Any bleeding is past 3 months? No. Major or minor bleeding, the major ones are when you lose 2 grams full of hemoglobin, 2 units of transfusion of RBCs, pericardial, cranial, intraspinal bleeding. This is major bleeding. This is, well, I know that my patient is high risk for bleeding. What shall I do in prophylaxis? We can use mechanical prophylaxis. This is important. We can use all mechanical prophylaxis rather than pharmacological and do heart team consultation. What is new? The guidelines February 2021 updates. American College of Chest Physicians said all acutely hospitalized patients should receive thromboprophylaxis. Low molecular weight fondaparinol should be thromboprophylaxis over unfractionated heparin and over direct oral anticoagulant. All of us are writing direct oral anticoagulant for COVID patient. There is no approval till now, just consensus. In critical ill patients with COVID-19 have proximal DVT pulmonary embolism, recommend parenteral anticoagulation, again, parenteral. What about the National Institute of Health antithrombotic therapy in patients with COVID-19? Use low molecular weight to protect critically ill patient against vena thromboembolism appear to improve prognosis. So when use low molecular weight, I improve mortality. Measure hematological and coagulation parameter. D-dimer, you can use the follow-up D-dimer in hospitalized patient. Hospitalized adult COVID received venous thromboembolic prophylaxis. There's a standard of care for other hospitalized like any others. Hospitalized patient not routinely discharged on prophylaxis. Not every patient has COVID routinely discharged on prophylaxis. My take-home message: steroid approved and improved prognosis, but not for everyone. No steroid for mild cases, except what we said. Hospitalized patients should be anticoagulated. Parenteral anticoagulation is the rule. No solid indication for NOACs. And thank you very much. Stay safe.
What? Okay. I have very few questions. Thank you very much. I have 2 questions actually. Many chest physicians in practice, when they find highly positive CT findings in outpatients, they give them anticoagulation. What's your opinion?
Actually, let's see what the international organization said. The only approved NOAC for post discharge from the FDA is rivaroxaban only 10 milligrams, and for 45 days after discharge in high-risk patient who you have screened and suspicious of having pulmonary embolism or PGI. It is not the rule to do this. And also the other NOAC are not approved. But it's still under FDA approved, but it's not the guidelines.
So we disagree.
Actually, there is parameter I have do for my patient. If my patient is high risk for thrombosis, so there is some sort of percent of time doing routine ultrasound in hospital and Doppler for both legs, but it is not also approved. But if you have something like that and high probability for pulmonary embolism, DC4 for example, I will do my practical.
I mean the CT findings, when you have a positive CT
سيتنج
finding
الوقت عشان المحاضرة اللي جاية بس.
in outpatient.
CT finding above the guiding for anticoagulation. For example, I have my patient with acute coronary syndrome and also treated anti-platelet and had infarction over apixaban. So NOAC are not the rules according to the CT finding. It's according to the high thrombotic burden of the patient.
شكرا دكتور فيكتور، وبنشكركم
Thank you
على
very much.
السادة الحضور.